Why, hello again. My name's D. Campbell, I'm a coding educator, and welcome to another one of my quick videos. This one's going to be about screening and lab orders, and how to make certain you're not getting denied. Screening labs work as follows. We have the Z11 family, the Z12, and the Z13 family of codes. This is what we're going to use whenever we're just ordering a regular screening lab for a patient. The key thing that I want to point out in this first, that a lot of providers will mess with these codes, is it's screening for asymptomatic individuals. Screening is testing for disease and disease precursors in asymptomatic individuals only. We only use these codes for asymptomatic people. So remember, it's screening for. You're screening for if someone has something. You're not using these codes for a patient who actively has a condition, or if there's a sign or symptom that describes what's happening to the patient better. So just make certain you never use a screening code with another code. So how the family and hierarchy works, how I wanted to teach it, is like this. There's a hierarchy to codes. We can only have one code from one single family, and you're going to pick the code of the highest value only. So we're going to use a Z11, Z13 screening code only. These are generally actually the lowest value codes. Their coverage is usually based off of the United States Preventative Test Screen Force, payer, or just current medical guidelines. That's how these codes work. These are basically the codes that you're going to use on a physical or a preventative visit only. And remember, it's for an asymptomatic person only. We are truly only screening for something. The next tier of codes will be our R family of codes. These are our sign and symptom codes. Whenever there's a sign or symptom of something, we would use that instead. And finally, the actual diagnosis code itself. All other families of codes. And then some Z codes actually will be in it, but that's where you will have the highest level. So only report one of these three categories per a patient, per the situation. So for example, I kind of broke down the lifespan of codes for a patient. So let's say we're only screening for anemia. Patient is currently asymptomatic. We will use Z13.0. Let's say a year later, we're having them come back and they had abnormal labs, and now we want to test them again. Now we're using R79. And then finally, this patient has now been established as they have iron deficiency anemia. This will be the code we use now on for every single blood order for that patient when that's what we're looking into. We will never do a screening for a blood disease again. We won't use the R code again. Instead, we will only use anemia. Let's say we have a patient who's non-diabetic. I think 35 is when you qualify for one of the screenings. We would use the screening only for diabetes. If a patient is pre-diabetic, then we will use an R73 code for that patient. And then finally, if a patient is definitively diagnosed with type 2 diabetes, we will only use an E11.9. So when that patient comes in for the A1C, if you order their A1C with a Z13.1, well, the patient actively has type 2 diabetes, you will get denied for that. Make certain you use the highest code every single time. An STI screening, Z11.3, don't combine it with an actual symptom. If a patient's coming in complaining about vaginal discharge, use vaginal discharge. Do not use a Z11.3 with the vaginal discharge. And then finally, you'll find a lot of these codes in the A family when the patient does test positive. Screening for cancer of the cervix, the first screening will be a Z12.4. Let's say the patient comes back and now they have bad results. We will use the R87.613 for the next test. And then finally, let's say the patient sadly has carcinoma, we will use the D06 for that patient and that one only. I wanted to do a mental health one just because they're not as commonly talked about, where we do have the screening mental health code, and then you will have the R family. There are signs and symptom codes for mental health, where I wanted to show the lifespan of a patient getting diagnosed with ADHD. or maybe it's just first the screening, then there's attention and concentration deficit, to finally the F90 ADHD code. That is how you will code for the patient. And then I have a tuberculosis one at the bottom here that we won't have to go through. But hey, that's basically how the breakdown will work. So just remember, you only use one of the three families at a time. You never use all three categories or you will have denials. So let's say we're purely screening the patient and we're outside the task window. What is another way to make certain our patient can get coverage? I would recommend you as the provider take advantage of your medical knowledge and use these long-term and current drug use codes. I know there's a lot of drugs out there, like lithium, for example, is going to have issues with your hepatic system, so that's going to cover a different stuff. You as providers know this information way better than any coder will know this, or any auditor will know this. So make certain you put in your notes why you're screening for a condition, maybe based off of a certain medicine that might be likely to cause something to happen. Take advantage of these Z79 codes and your expertise, because truly your coders don't have that expertise. I will admit right now I have very limited knowledge on how certain medicines are going to progress in an individual patient. So you as providers take advantage of that, so that way when you are ordering a pure screening for a asymptomatic patient, maybe take advantage of those medicines that might help them. Other codes that can help is in the situation of STI screenings, for example. The Z20 codes can be very helpful to help give more information that can help with getting it coded and getting it paid for. So if a patient was exposed to a sexually transmitted disease, and key phrase here is suspected as well, they don't have to know that their partner was it. Maybe the patient just had a new partner and they're concerned about it. These codes are going to help make certain you get higher payment for these and making certain there'll be less denial. Something I want to point out with STI testing, sorry for all the tabs I have, is chlamydia screenings, for example. Insurance is going to be paying usually based off of these STI screenings, based off of what the United States Preventative Task Force has it issued as. For females, you have a higher chance of it getting covered with only a Z11.3 code. But males, you actually have pretty much no chance of it getting covered with only the screening code, because males aren't actually recognized as possible asymptomatic carriers by them for screening to happen. I've looked into this quite a bit. I guess the reason for it is obviously male genitalia is external, so the likelihood of us not knowing we have an STI is a lot lower than a female being asymptomatic with it. So that's why screening is more likely to cover with a female patient. But if we're talking about a male patient, it does lower your likelihood of getting covered with just a Z11.3. So that's why I do like pointing out these Z20 codes, as they will help quite a bit with increasing the likelihood. Other codes that can help are family history codes. When you're ordering purely a screening, attach the family history code of what's going on with this patient's history that may make it more reasonable to order the screenings more often or outside of the usual window. So make certain you take advantage of the family history codes when you can as well. And then finally, what I want to just discuss here is the guidelines that break it down for COVID. COVID is a perfect example because it all has guidelines for every single step and story of the situation here. Where COVID has specifically the screening guidelines for if we're going to be doing a COVID screening, we're going to use the Z11.52. If there's exposure to COVID, use the Z20 codes when appropriately. Next, it breaks down sign and symptoms without definitive diagnosis of COVID. So if a patient presenting with sign or symptoms associated with COVID, but a definitive diagnosis has not been established, assign the sign or symptom codes to it. That's what we're going to use, not the screening codes. And then finally, if a patient has definitive COVID, we will assign the COVID diagnosis. And then just always remember, if you're an outpatient provider, do not use any of these swear words. Suspected, possible, probable, or inclusive. If you use any of these words, then instead the sign and symptom codes must be reported because definitive language isn't used there. Let me move my blob here real quick so we can see what I'm talking about here. So these guidelines down here for the uncertain guidelines is all what this is again, is just the uncertain guidelines broken down for specifically COVID. So that's it. That's my video here on the subject of making certain your labs don't get denied often and just how to tell the story better. So just remember, it's one pocket for each individual code for each individual patient. Do not do a screening code, a sign or symptom code, or a definitive diagnosis all on one patient. Otherwise, you are very likely to get denials. Make certain you follow the hierarchy of codes and try, if you are doing only screening as a provider, give us as much information as possible. Tell us about their medicine. Tell us about exposure. Tell us about family history. Tell us anything that makes this patient more high risk and it'll justify the screening. And that's it. That's how we do sign or symptoms, screening labs, and making certain we get coverage. My name's D. Campbell. Thanks again for watching another one of my videos. Bye now.